stenosis. So what is renal artery stenosis? It's no more than restriction or basically narrowing of one or two of the renal arteries. So therefore, decreasing the tissue perfusion to the kidney. Okay. So what are the major etiologies of renal artery stenosis? Renal artery stenosis, the most common etiology is associated with atherosclerosis. And therefore, because there's a plaque of atheroma obstructing the proximal renal artery, that therefore decreases the perfusion of the nephron, decreasing glomerular filtration rate, and of course affecting the renal function, producing what is called renal vascular hypertension. Okay? The second most common cause of renal artery stenosis is another disease process, which is called fibromuscular dysplasia. Fibromuscular dysplasia is not an inflammatory process. It is not an atherosclerotic process. Most commonly, this is associated with congenital diseases, patients that are predisposed to have occlusion of any artery in the body. Could include the retinal arteries, the cerebrovascular arteries. These patients tend to have strokes for unknown reasons. Sometimes they do have mesenteric ischemias and so forth. So these patients again have a congenital disease predisposition for arterial occlusion all the way in the body, but the cause is not determined. Most commonly, because again, it's not produced by an occlusion of an atheroma plaque or hyperlipidemia, and it's not produced by any type of endothelial injury affecting the arteries of the body. Very, very common in young adults and most commonly in women, okay? So whenever you see a patient that is a very young patient that has, for example, stroke or mesenteric ischemias or blindness, acute blindness, or renal artery stenosis, without having any type of atherosclerotic plaque that could be seen in an angioplasty, these patients most likely have this congenital disease, okay? Okay? Other disease process, I'm going to go through the pathophysiology in a second. Other disease process that can also produce renal artery stenosis, for example, if you have a coarctation of the aorta, of course the blood flow going through the renal artery will be diminished. Any type of vasculitis, such as, again, if you have all the diseases that we already covered last week for glomerulonephritis, can also produce renal artery stenosis. Radiation therapy, chemotherapies, that even dissection of the renal artery by an incidental or iatrogenic encounter during surgery, okay? Or an actual thrombi event. So, what are the initiating factors for atherosclerotic induced renal artery stenosis? So again, you know more than anybody how the plaques of atheromas can produce coronary artery disease. Exactly the same way, there's an occlusion of the proximal artery that perfuses the nephron. So no more than patients either due to obesity, patients that have hypertension, and they do have endothelial injury, and then atheroma plaques that are deposited at the level of the artery that occludes the vessel, therefore producing ischemia, okay? Now, other risk factors that the patients can have, of course, cigarette smoking or diabetes or even high levels of homocysteine that induces any type of artery occlusion, okay? We have gone through, again, CAD, how these atheroma plaques can also break down and embolize. And if it happens anywhere in the body and embolizes that goes and is lodged into the renal artery, that can produce the occlusion of the renal arteries and therefore renal artery stenosis. So far, so good? So how does the body compensate? Well, this is just the explanation of how, the atheroma plaques dislodge, and in patients that have high levels of LDL, they are very high risk to produce atherosclerotic type of renal artery stenosis, which is the most common etiology. Now, what we need to remember is that before we go into here, I'm going to explain the pathophysiology. Remember that normally whenever there is tissue hyperperfusion to the kidney, you have the autoregulatory response, which is the angiotensin-aldosterone system. So no more than when there's hyperperfusion, what happens first is that there is vasoconstriction at the level of the afferent arteriole produced by the catecholamine response producing vasoconstriction, right? If that does not improve perfusion in the body, in this case we're talking about the kidney, what happens is that the renin is released by the juxtaglomerular apparatus, and that activates the release of angiotensin 1, which is present at the level of the kidney, but also is brought down from the liver to be able to produce vasoconstriction, okay? If that does not improve the perfusion in this organ, what happens is that there's a conversion of angiotensin 1 to 2 by angiotensin converted enzyme, which is present in the proximal renal artery, okay? So the pre-renal arteriole. Then if that vasoconstriction does not improve the tissue hyperperfusion, then you know that it will be released aldosterone by the renal tube, or in this case distal, and also by the cortex of the adrenal gland to be able to produce more vasoconstriction and reabsorption of serum water. That is also done by the ADH, which is also released by the posterior pituitary, right? Only reabsorbing water. Now I want you to concentrate about only the portion of angiotensin release, okay? So if you know that one of the major mechanisms for autoregulatory response of the kidney, when one kidney is occluded, okay, there is, remember, as I explained last week, there is a hyper-functioning of the normal kidney. So the other kidney that is not having this ischemic episode is trying to overcome the functions that are diminished in the affected kidney, right? So there is hyperresponsiveness, release of renin and angiotensin to be able to perfuse and maintain glomerular filtration rate. So far so good? So what happens when you have both kidneys with renal artery stenosis?
They don't get.
They also do try to auto-regulate, right? But the problem is that if both have an ischemic episode, you have more likelihood to go into acute renal failure faster than if a patient has one kidney only affected, okay? So I want you to only keep that in mind so far, all right? So the autoregulatory response is really important for the kidney to be maintained in order to avoid acute renal failure, okay? Now the problem comes in, because this is a contradiction about treatment of this disease process, the problem comes in when the disease process is not recognized on time, and the kidney that is not affected in unilateral renal artery stenosis goes into a vicious cycle. Mm-hmm. Then the release of angiotensin 1 and 2 will be more detrimental than beneficial. The same example so you could understand, let me give you the example of hypertension. You have hypertension, at the beginning you also have the RAS that is released, right? Any changes of pressure or volume, RAS is also activated, right? What happens when you don't treat hypertension properly, or when the patients, for example, come late to you to have uncontrolled hypertension treated for the first time, or if the patient is being already diagnosed with hypertension and the patient is not compliant to medication, patient already comes late into your service to be treated. Isn't that heart already with a left ventricular hypertrophy, and that heart is going through remodeling, and that's the reason why the patient goes in to see a chef? The same thing happens in the kidney. At the beginning, the autoregulatory response of the renin-angiotensin-aldosterone system release is beneficial for the kidney that is not affected. But later on, since unfortunately this illness is not tested on your boards,
We bring it off because it's highly missed, highly missed. And when the patients come already to you, they already are going through an overwhelming cycle of activation of renin-angiotensin-aldosterone system. And this is more detrimental for the kidney that is not affected than beneficial. And that's the reason why there's a major contradiction that you would see at the end to give or not to give ACE inhibitors. Okay? That is what I want you to have in your brain. Okay? Okay? So
you got it.
Now, going back, because like almost 10 slides talk about what I just said, going back to fibromuscular dysplasia, remember that the most common etiology for renal artery stenosis is atherosclerosis. The second most common cause of renal artery stenosis is fibromuscular dysplasia. And as I told you, this is not an inflammatory condition. It has nothing to do with obstruction of the renal arteries by atheroma plaques. This is just, unfortunately, a congenital disease, a familial predisposition, okay, to have occlusion, repetitive occlusion, or multisystemic occlusion in arteries that can affect any organ in your body, from the retina, carotid, occlusion, okay, renal, mesenteric, even cerebral arteries that patients have what is called radiographic string of beads. When you do an angioplasty to this patient, or CT angiography or an angiogram, you will be able to see this. But again, many times it's caught in autopsy. Okay? So, it is highly commonly present again in young adults or middle-aged adults, never elderly patient. Because remember, the majority, even though we're having younger and younger and sicker patients now, the majority or expected patients with atherosclerosis and damage at the level of the artery, coronaries, or renal in this case, will be elderly population, right? That's what we expect, even though we are having younger and younger and sicker patients. So, but you never expect to see a patient so young, less than 40 years of age, with a stroke, or having a patient with less than 40 years of age with renal artery stenosis, okay? But when you don't see the obvious causes, like the patient has hyperlipidemia with a high LDL, what could it be? Most likely fibromuscular dysplasia if the patient is a woman. I had one patient like this and she went brain dead. This is a patient, listen to this, just by the clinical scenario, tell me, the majority of these patients do not have a familial predisposition for hypertension. You look in their history, you look in their family history, and they don't have hypertension. They don't have diabetes. They don't have any risk factor, they have never smoked. So you look for the risk factors and they're not present. The patient that we had was a 36-year-old woman, and more fit than her, nobody would be. She was an athletic, she would do competition cycling, and she came into the hospital with a massive intracranial hemorrhage. Okay? After, of course, she developed, basically at the beginning was ischemic, and she converted quickly into hemorrhagic, and she went brain dead. And all the labs were completely normal. You know that when a patient comes with a stroke, you do an entire workup. You do TSH, you do lipid panels, you do everything, and everything was normal. We weren't able to see these bits of stream that it's like, it looks like a rosary in your arteries, because nobody will go do further studies for her. She was declared brain dead, and the husband donated her organs. So the rest of the studies were done for organ donation. But if she has no past medical history, no risk factors, no familial history of hypertension, and now she comes in with a renal artery stenosis, what could it be? Okay? I know it's going by itself. So, again, and I'll show you in one of the radiographies how that string of beads looks like. Okay? So again, as I said, this is no more than what I just explained to you. So basically what happens is that, whenever the kidney goes into hyperperfusion, there is an increase of pressure at the level of the pre-renal arteriole, and therefore that increases the hydrostatic pressure, and to be able to improve the glomerular filtration rate, right? And basically the patients with renal artery stenosis are dependent on the renal angiotensin aldosterone system, so the RAS system, and to be able to maintain our regulation, okay? And what happens is that if you have a unilateral narrowing of one of the arteries, the other kidney again tries to compensate or hyperregulate. And then what happens is that if the cycle continues to be vicious, it produces a disease process, which is no more than renal vascular hypertension. So if the kidney cannot overcome autoregulatory response, what happens is that the patients would develop signs and symptoms of hypertension, okay? But in this case, the hypertension is not developed by, for example, obesity or sedentary lifestyle or having any other risk factors, but it's developed directly from the ischemia that the renal artery is going through, okay? So again, you can read that on your own. Basically what happens is that, again, catecholamines are released, and renin-angiotensin aldosterone system is released, and you know what aldosterone will produce, reabsorption of thermal water, to be able to increase glomerular filtration rate. And again, basically there's a major contradiction to try to abolish or inhibit the renin-angiotensin aldosterone system pathway with ACE inhibitors and ARB, but we're going to go that in a second when we talk about the treatment. Okay? So what are the clinical findings and what is the criteria that I want you to remember for renal artery stenosis? Okay? So first of all, this is a patient. Do you remember when we talked about pheochromocytoma in endocrine system, even though I was not your lecturer? One of the major criteria of pheochromocytoma is this patient that continues to have uncontrolled hypertension despite proper treatment. Most of the time, these patients are on 3 or more antihypertensive medication, and even though that you have ruled out already the possibility of non-compliance, the patient continues to have hypertensive event, okay? And this is not only an isolated hypertension, but this is a hypertension that goes rapidly and progressively into renal failure. You know that normally a patient with hypertension, it has to take several months, several years to develop the complications of it, such as retinal AV leaking or hemorrhages, to be able to have hypertensive nephropathy. So to be able to have all the complications associated with hypertension, left ventricular hypertrophy, etc., you need several months and years, right, of uncontrolled hypertension. But these patients go really quickly into renal vascular disease after the patient has been diagnosed with hypertension. Most of the time, the patient is not a hypertension that is 150 over 90 or 154 over 90. This patient is properly treated in 3 or more antihypertensive medication, and they constantly come to you with either malignant hypertension or exactly associated with papilledema, left ventricular hypertrophy, chest pain, the MI, etc. All the complications of it, or hypertensive urgency. Okay? And I'm sorry? Sorry. So the key word is resistant hypertension with proper treatment. In addition to that, when you have a patient in the hospital, okay, unfortunately primary care physicians don't right away order a renal ultrasound on a patient that has uncontrolled hypertension, unless they have gone several months with it and they see BUN and creatinine affected. That's when they do the renal ultrasound or they refer to a nephrologist. But when these patients come with uncontrolled hypertension, since you have to determine the difference between hypertensive urgency versus emergency, right? Even though I understand that in the ER, you have no time for that and you treat the same, I understand that, but the major goal is to do a renal ultrasound as one of the diagnostic studies to be able to determine if the patient with hypertension has already suffered end organ damage, right? To be able to qualify this patient into hypertensive emergency. So when you do a renal ultrasound of the patient would have already an atrophic kidney. Remember that a normal kidney should be more than 7. Okay, so it's less than 7 centimeters. Okay, now you know that the first line treatment for hypertension, if you're not a CKD patient or diabetes, is diuretics. Now what happens with this patient is that when you give the patient's diuretic, hydrochlorothiazide for example, what happens? The renal function becomes worse. Or another key point is that when you give the patients ACE inhibitors or ARB, the renal function deteriorates. What can happen?
Because they cannot really regulate.
Exactly. Because at the beginning, in the initial stages of renal artery stenosis, fortunately, if you're able to cut it on time, okay, since the kidney that is not affected is trying to overcome the tissue hyperperfusion of the one affected with ischemia. If you blunt that autoregulatory response, what happens is that the renal function, instead of getting better, and the hypertension instead of getting better, the patient is getting worse, okay? That is another indicator of renal artery stenosis. And as I said, look for the patients with atherosclerosis, with a high LDL. Of course, this is going to be patients more than 50 years of age, but if the patient is less than 50 years of age and is a woman having all these conditions, try to look for possibility of hypertension. Okay? In addition to that, as I said, even though this is not a disease process that you will think right at the beginning, okay? Unfortunately, it's one of the diagnoses of exclusion, but having no family history of hypertension, like for example, my father died at the early age of an MI, but he had hypertension. My mother had diabetes and hypertension. So if I develop hypertension, well, it's the family history, right? It's in my genes. But these patients do not have any family history of cardiovascular conditions at all, okay? Even though they could or not have risk factors as patients with regular or essential hypertension. And again, this is a very highly key indicator. You know that ACE inhibitors are the best, right? Are the best. Even though they're not the first line treatment for patients that are less than 65 years of age that have no comorbidities, if you give it for the first time, it should not produce a deterioration of the blood pressure itself or the renal function of the patient. So if it produces that, then you have to suspect the possibility of renal artery stenosis. In addition, many patients is described in UpToDate and many guidelines as well. These patients, sometimes the first and only presentation that they have in hospitalization is a flash pulmonary edema. They have recurrent flash pulmonary edema. I don't know if you're aware that when the body is under so much stress, in this case, severe hypertension, or for example, tachyarrhythmia, such as rapid ephemeral flutter, or SVTs, patients can go into flash pulmonary edema, okay? So one of the conditions that could put the patient into constant flash pulmonary edema is renal artery stenosis. And again, you diagnose a patient with hypertension 3 months ago, how come you already have endoscopic examinations abnormal, like AB leaking and cotton wool spots and retinal hemorrhages? There's no way, okay? I understand that you might say, well, but you just saw the patient 3 months ago, but maybe this patient's been having hypertension already for 5 years and never came or never had insurance. True, could be possible. But again, if this is the first time and the patient denies having any events before, 3 months is not enough to develop complications for hypertension. And if it's so fast, so acute, so deteriorating, you have to rule out renal artery stenosis, okay? And again, patient going into renal failure really, really quickly. Just,
After you
Yes.
start the ACE and the ARBs, like when would you check the levels? Like how long, like, cause it, you know, that goes against like the guidelines that we learned that I have like itched in my head. You think it's the ACE and the ARBs, and if that doesn't work, then you add like, you know, either you up the dose or whatever it is. So when
Right.
do you check the
Right.
creatinine and all that wonderful stuff
Right,
to make
but-
sure you're
okay.
not damaging the kidney?
okay, normally when you receive a patient for the first time and you treat the patient with any antihypertensive medication, you should bring the patient back in 1 week, the first time. The first time, 1 week. And mostly when the patient comes, you're not gonna send the patient home. Okay, first of all, if I receive a patient with 220 over 114, I'm not gonna treat in the office. You go straight to the hospital. But let's imagine that you're not following the guideline and you say, okay, let's start with this medication. You would not put this patient in 3 months to do a follow-up,
No, so
right?
you do
So you
an
have to
active-
bring, you do baseline laboratories. You bring the patient back as a follow-up and the blood pressure doesn't improve. But the minimal that you have to do with ACE inhibitors is to check electrolytes, right?
Yeah.
So by checking electrolytes, you're already doing a BNP at least minimum.
Okay, so like a week after, so I wanna know like, cause what if in the inpatient?
Oh, inpatient,
I'm
you
sorry.
do it every day.
Yeah, you do every day, but like.
Inpatient, you do it every day.
Yeah.
I have not
No, I
seen
know,
any
because I'm
patient in
saying,
the
like,
hospital that
next
you
day-
do
okay,
labs
so
every day.
you spend on ACE the next day goes up a little bit, we will stop it? Like, you know what I'm saying?
Well, really depends. Really depends. I mean,
How-
all the
how-
factors
Okay, so I'm
that the
saying, like,
patient.
what's the, when do you, I don't know.
Really
I'm
depends on-
asking, I'm sorry.
If you know the family, if you know the
I'm
family.
asking like.
Exactly. It really depends on all the factors that the patient is having. Because, for example, imagine that this patient comes in. Remember that there's always like exceptions, right? To any rule. Patient comes into the hospital. The patient has pulmonary edema, right? The patient has pulmonary edema, and the patient is also hypertensive. Okay, and you start an enalapril, which is the most common that we use in the hospital, for example, for hypertensive emergencies. And you start the patient on an enalapril, but at the same time you put the patient on Lasix because the patient is in pulmonary edema. Well, you know, you're not going to suspect renal artery stenosis at that time because it's common sense that if you are dehydrating the patient with a Lasix, ACE inhibitor is going to make the renal function worse because the ACE inhibitor is not allowing autoregulatory response. I understand you completely. You know, this is in clinical practice. You're not going to say, "Oh my God, the ACE inhibitors put the function worse, BUN creatinine worse, so I have to stop it and I have to suspect renal artery stenosis." This is not a one-time patient. You know, this is a patient again that you appropriately treat. And the major concern when the patient comes with pulmonary edema to the hospital is to know the cause. What happened that you're in pulmonary edema? And the first thing that you have to do is, again, diuretics to decrease volume, and also you're going to do an echocardiogram to see why the patient is in pulmonary edema, right?
Yeah.
And if your echo is completely normal, then you have to find causes related to, for example, lung diseases, right? You're going to do a CAT scan, etc., right?
If a patient has the renal artery stenosis and is not getting treated with any type of diuretic, it's specifically just an ACE inhibitor. How long do they have to be on this ACE inhibitor before you actually see this 15% creatinine increase?
Oh, this could happen in less than 3 days. The worsening of the renal function can happen as fast as 3 days. Okay? Any other question? Again, I mean, don't think about a one-time event because this, again, doesn't happen. I mean, the patient can have renal artery stenosis, don't get me wrong, but you will never ever suspect for the first time renal artery stenosis. You always suspect essential hypertension, right? Which is, remember, you have 2 types of hypertension. You have essential hypertension, which is no more than a RAS system, right, that is producing this, and you give a patient the guideline for treatment based on JAC 8 and 9, okay? And you have the secondary hypertension, which is related to disease processes. Now, when you receive a patient with hypertension, hospital or outpatient, because you can work outpatient as well, okay, in specialty, high acuity specialties. If you're working with internal medicine, your job is to investigate the causes and rule out secondary causes of hypertension before you can say, this is essential hypertension. And what do I have to do to rule out? So let's start with coronary artery disease. You do an EKG, you do your troponin, you do your echocardiogram, right? To be able to rule out possible causes of hypertension. Let's go down and let's do a thyroid panel, at least TSH T43, to see if the patient has hyperthyroidism that can be produced in secondary hypertension, right? If we continue going down, can we have, for example, pulmonary hypertension that can give me as well secondary hypertension? Because pulmonary is connected to the right ventricle and can produce heart failure and therefore hypertension as well. So, but you can see that on the echocardiogram as well, okay? What else can I have that can give me secondary hypertension? Well, the minimum that you would do is look at the PUN and creatinine and do a renal ultrasound to see if the patient is having any type of renal disorder that is giving me hypertension, okay? And then after that, you might think about endocrine disorders that might give you hypertension. For example, patients that have pheochromocytoma. You don't think about pheochromocytoma for the first time. The same way you do not think about renal artery stenosis for the first time. But it's your job to rule out secondary causes of hypertension before you say this is essential. There's nothing giving me hypertension secondarily in other organs, and therefore what I have is an instability of the RAS. Do you understand? Okay? So that's the reason why when the patient comes to you for the first time, you will never think about renal artery stenosis unless the patient will tell you, hey, I don't know what to do, you know. My PCP is already having me on metoprolol, I am on dialtosen, I am on lisinopril, high dosages. I'm on clonidine PRN. And I even had an acute coronary syndrome in the past, you know, an angina or whatever, and I'm even having isosorbide, you know, long-acting nitrates, and still, I have hydralazine, I have multiple antihypertensive medication, and I take it every day, and have been extensively worked up for secondary causes, and nobody can find the reason why I have hypertension. And then you do a renal ultrasound, and you see an atrophic kidney. That's when you have high levels of suspiciousness, and then you continue the investigation. Do you understand? Mm-hmm. Okay? So this is not an isolated cause. Okay? So of course, they can have exactly the same risk factors as any other patient with essential hypertension, but again, this tends to be most of the time, not at 65 years of age, this tends to be the patient that has never had any familial history, most of the time, minimal risk factors compared to the patient that has essential hypertension, even though they can have them all, okay? But this is not the most common presentation for them, all right? And they develop hypertension and a rapid deterioration of end tissues or end organ damage, and therefore renal function as well gets deteriorated really, really quickly, okay? How would you diagnose or differentiate acute renal failure versus renal artery stenosis? Can they give you acute renal failure if you have a patient with renal artery stenosis? Of course, of course. But now, will the renal function improve with just fluids?
No.
That will be one factor of differential diagnosis. It doesn't help. You give diuretics and it gets worse. You give ACE inhibitors and it gets worse. You give fluids to see if the patient has acute renal failure, pre-renal, and it doesn't improve. You try to look for medications that can be an insult for the kidney, and there's none, or if there is, you remove them and it doesn't help. Okay? How can you differentiate, for example, chronic glomerulonephritis with a patient with acute renal artery stenosis? You can't,
Eventually.
because eventually they're gonna go to the same route.
It's just much faster than the other.
Okay? So again, this is so difficult. This is so difficult to differentiate this disease process among others secondary causes of hypertension. And as well, this is so difficult to differentiate this disease process among all the complications associated with acute renal failure. You have to have a high levels of suspiciousness and investigate when the patients are compliant and they continue having 3 or more antihypertensive medication and the hypertension does not improve. Okay? Of course, I don't have to read this, but as long as they already developed in a very narrow or short time renal vascular hypertension, that means once the patient has a detrimental renal function, you have the same morbidity and mortality, the same prognostic factors as when the patients have, for example, intrarenal renal failure produced by, prolonged ischemia. Okay? So again, once you have all the end organ damage is the same as essential hypertension, you're not going to correct having AV leaking. You're not going to correct having already nephrosclerosis. You're not going to correct having a stroke as a major complication of renal ischemia. Okay? But what you can correct is try to identify the disease and treat properly. Okay? To avoid further deterioration of end organ damage. So what laboratories can we do? That many, of course, are essential for any type of hypertension, and others are specific for renal artery stenosis. We're going to go through the cheapest, the initial test, versus the gold standard examination. Okay? So let's talk about BUN and creatinine. So how are you expecting to see the BUN and creatinine on a patient that has renal artery stenosis? With the values, if it's caught on time, with the values of an acute renal failure, right? So if you do a 24-hour urine and the patient already has nephrosclerosis, what are you expecting to see? The same values of having glomerulonephritis, right? You're going to have proteinuria, less than 3 grams. You're going to have hematuria, right? You can have edema, for example, as a clinical symptom, right? And the BUN and creatinine ratio, of course, is going to be elevated. So you're going to have exactly the same values. So far, what I have told you, is it valuable to differentiate renal artery stenosis among the others? No, right? Not yet. Okay. So what else can you investigate? Well, you would see with me that many autoimmune conditions can give you not only hypertension, not only left ventricular failure, pericarditis and myocarditis and all that, but many, many autoimmune conditions such as lupus, rheumatoid arthritis, Sjögren, etc., or scleroderma can also give you acute renal failure and glomerulonephritis. Okay? So at least, meanwhile, you can do the same thing as any other secondary hypertension. Investigate secondary causes that can give you hypertension, such as autoimmune conditions, right? That's another one. So far, we have not done anything to be able to differentiate one from the other. We don't do the captopre test anymore, but you have been asked over and over and over on board examination about this exam. What do you think will happen? Exactly. So basically what you do is that you do a baseline renin. You do a blood test and you measure renin, the baseline renin of the patient, right? Exactly. And then you administer a patient an ACE inhibitor. In this case will be captopril. So what do you think would happen? Not only the renal function becomes worse, and the hypertension becomes worse, but the renin value increases. Why does it increase? Because the kidney in this, I'm talking about unilateral renal artery stenosis. If the patient has a unilateral renal artery stenosis, that the other kidney is able to compensate, You're blunting autoregulatory response, so the normal kidney is gonna overcome it even more. So the renin will be exaggerated, the release of it. No, the actual jump is more than 10%. Okay?
So then you said this is not normally done anymore? Why is this?
No, why is not normally done anymore? I know,
Undo
I have
the
to
transition.
adjust that.
Dr. Leal,
It's not normally done anymore?
transition.
I know. Okay, let's do this. Let's end the show.
No, you can leave it like that, just transitions.
Just gonna hold. Okay, so why is it not done anymore? Do you think that, okay, the risk of death,
If you increase the risk, the running, you're like increasing the vasoconstriction and everything, so you're gonna put the patient more hypertensive and all that.
you're gonna put the patient in hypertensive emergency if the patient was not on it. The patient can have a stroke. This was done in the past, and it was done, of course, in a very secure environment such as ICU. Okay? But you need to be aware of the test because it's still in the guideline. Alright? So this is a very valuable indicator that the patient has renal artery stenosis. But do you really have to do this test? If already having the history of giving ACE inhibitors to the patient makes the hypertension worse and makes the renal function worse, you already have the test there. What do you have to measure?
What happens if it's bilateral?
The problem with bilateral renal artery stenosis.
There's not much you can do unless you go out and do the.
The problem is that both kidneys are already compromised, okay? Unless it's an initial stage of, at the same time, bilateral renal artery stenosis, which is rare that it happens. You have to like throw two emboli at the same time, okay, to occlude both renal arteries, or unless you have a coarctation of the aorta, since the renal arteries are a branch, a proximal branch of the aorta, has to be like at the abdominal aorta, the major problem to have bilateral renal artery stenosis. So at initial stages, you do have release of RAS, but then after that, this is not a value at all.
Do they do anything if it's partial stenosis? Like sometimes you read them like 70% of stenosis or 50% of stenosis.
Yeah.
The same as carotid artery stenosis, when you have more than 70%, you should intervene surgically.
Does it go if it's symptomatic or not, or just?
It doesn't matter. It doesn't matter. Okay? So another test that can be done that is also at the same time a predictive value of prognosis. And prognosis not only for recovery of renal function, so not only a prognostic value for renal function, but also prognostic value for mortality, okay? So when you do on a patient a renal ultrasound and you use Doppler, you're able to measure the pressures of that renal artery, okay? And basically you measure the pressure of the artery and the vein, because every single organ has an artery and a vein. So you measure the ratio of renin, artery and vein by Doppler, okay? And if the ratio is more than 1.5, okay, in the contralateral kidney, the patient, of course, has renal artery stenosis, but not only that, I know that already, because the velocities and the pressures are increased in the kidney affected, but the renin is exaggerated released in the contralateral kidney, but normally the pressures, the velocities by Doppler should be less than 0.8. So when they're higher than 0.8 or less than 1.5, the patient has a very good prognosis that if you intervene, for example, by putting a stent to be able to dilate the renal artery, for example, the renal function recovery and therefore mortality is less compared if you have already a high velocity of more than 1.5. Okay? You will never do this. This is done in IR, in the OR. This is basically a procedure that is done, but you have to know how to interpret this.
So you said that the normal velocity is?
Normal velocity is less than 0.8. So basically when you measure the pressure by Doppler inside the artery and you ratio it by vein, okay, because normally a vein has a less pressure or velocity than the artery, okay, the ratio proportion between the vein and the artery should be less than 0.8. If you measure it and it's 0.8 to 1.5, it's elevated, but the patient at least has a good prognosis that if you intervene with stent placement, okay, and you decrease the pressure, the renal function recovery is highly expected compared that if your velocity is already more than 1.5.
Is that stent permanent forever, or is it just a period of time and?
I mean, you do surgery after. But yeah, it's the same way you put a stent in the coronary arteries and they stay there forever until the patient worsens and then you decide to do a couch. Same thing, okay? So again, same thing. Renal ultrasound. You could also do captopril renalography, which is essentially the same principle as the captopril stimulation test, but this is done through an angiography at the same time. CT angiography is what we do the most in our clinical practice. Now, tell me the major negative effects of this. Patient is having renal artery stenosis. Patient is having decreased tissue perfusion and therefore already having elevated BUN and creatinine. It has to be a life and death situation that is never present in these patients for you to do CT angiography because it uses contrast and that could affect the renal function even more, producing contrast-induced nephropathy. The same way as we do in CAD, in coronary artery disease, you actually put the patient at risk for contrast-induced nephropathy and having the patient have, for example, percutaneous coronary intervention and put a stent placement or send the patient to stress test using contrast when it's a life and death situation, okay? That the kidney is the less of the worriness. The ratio between artery and vein.
Would they consider doing this and then dialyzing the patient?
You could do that as well, but.
Like they would really like.
But we have better technology. I mean, what we can do, for example, MRA, because even though it uses gadolinium, it's not as invasive. It doesn't produce as much as contrast nephropathy as iodine. So you could do an MRA as well, which, as you could see, has a very high sensitivity and specificity as well, and it's not as invasive as the CT angiography because you have to put a catheter through a major artery, which is in this case could be brachial or radial or femoral. Okay. Now I want you to look at this is normal completely. So you have the kidney. Okay. This is the ureter. This is the pelvis and the calyces. Okay, and this is the, oops, oh, it keeps going.
Oh,
We didn't fix
could we
it.
save it? Click and save it.
Oh, maybe.
You must
Okay.
be in presentation mode or something.
Yeah, just stop the.
It's back on.
Yeah, it's back on there. Uncheck the
right.
box there. Yeah. There.
One mouse click
Yeah.
after whatever.
Save.
And go again and then save it.
How do you save?
And the little
Control S.
Oh.
Okay, so this is the renal artery. Okay, again, branch of the aorta. So I want you to pay attention to the actual renal artery, so you can see in the next slide the stenosis, and also concentrate on the image of the kidneys, so you can see how they disappear. Yes, this is with contrast, with an MRA with gadolinium. Okay, now, what is the gold standard examination?
Ultrasound.
No ultrasound, no ultrasound. What is the initial exam? An ultrasound, because you will be able to see the atrophy And you can even use by Doppler, so you can measure the ratio of vein and artery pressures. But the gold standard examination, again, you don't see it much in the hospital being done, not even the CTA. Why? Because of contrast.
Oh, yeah.
Okay?
So how this one is gonna be the gold
Is that an
standard?
ultrasound? Renal and
No, it's actually going through the artery as well and putting contrast, so you can actually depict all the arteries.
So they do that? They really do it?
Well, again, you don't see it as much because you're not gonna induce
Another
more
part.
nephropathy and
That's
infection.
what-
Okay?
So basically that's the best way, it's just.
It is the best way, but unfortunately,
Ah, okay, that's what I'm saying, how else one is gonna be the gold standard, it's gonna put the patient on more.
Can you give them fluids?
again, it's the gold standard. For example, what would be the gold standard examination for you to see DVT? Tell me. No, it's not.
PQ.
It's actually a venography. No, we don't do that.
Going into the veins.
Why don't we do that? It's very aggressive, but it actually will be the best way to see the clot. And even to see and differentiate if this is an acute clot or a chronic clot. We can induce by ultrasound based on the mobility of the clot and also the walls of the artery.
That's what I was thinking, I'm like, I'm pretty sure I've seen the reports and say they have.
Exactly. We can induce or infer that this is a chronic clot based on all the factors surrounding the vein. But in reality, the best way to diagnose a DVT is by venography. But we don't do that. First, it's a very aggressive procedure. And second of all,
Can't do that on everybody.
you have to use contrast as well. Okay? So again, you have a patient, you receive by this,
Yeah, you can.
yeah, it keeps moving, so I know. So what else can you do? Not only you can do a renal arteriogram by itself, but you could also use what's called digital subtraction angiography that we also use it for patients with stroke. That this is no more than you take away all the soft tissue, and when I say soft tissue, all the organs surrounding the abdomen, okay, in the imaging, okay? So basically excludes all the soft tissue and you only see the kidney and the arteries itself. So it's actually higher specific than a renal arteriograph by itself using iodine, okay? So this is digital subtraction angiography. As you can see, you don't see any organ outside at all, okay? And if you look here, there's a major stenosis here. Even though it's not reported,
No way.
even though it's not reported, look for the thickness here, and look for the thickness here. Okay?
Are you gonna say that this is common sense and obvious?
No, it's not. I'm not gonna put these images in your exam, but I have to show you.
The left
Okay.
is the left, right? The left is the right and the right is the left.
This one as well, you have, I want you to look at the contrast. Please look at the contrast. You have contrast here, and then the contrast disappears. Do you see it or not?
Yeah.
Okay, so,
Where does it disappear?
I like
The
There,
light
right there,
is where
it
it
says
disappears.
okay? Now, I want you to look, for example, the image here, okay? And look at the kidney very, very, very well depicted here. And this is like model in some parts, already with cortical atrophy.
So it's not that one is bigger than.
I don't have to go there?
No.
So I want you to look here that this kidney has the entire cortex. Do you see it or not? And here is like cotton, like some white spots all around because the cortex is already atrophic. Okay? Do you see the right kidney?
No.
You see the renal arteries here?
Yeah.
And this is all gone. Okay? It's gone.
It should be a
You
dark.
see the image of the kidney here? Not at all. not even the renal arteries. This is the renal artery. And there's no renal artery on the other side
So
at
that's
all.
necrotic?
No,
Because
it's
that's-
completely stenotic.
That's where the contrast is, obviously.
Yes.
But you
yes.
don't see the darker image of the.
So the,
Of the kidney. Not even the renal arteries. Look at the renal arteries right here, in this side. Tell me where they are here.
Yeah.
They're not.
so that's
Fine.
the right, that's the right over
They're
there.
right.
Esa está jodido.
Jodido.
Sorry.
We're
What about here? Even though they do have bilateral renal artery stenosis in this patient, you're able to see the image of the right side better than the left. The left is like a shadow. Okay? Again, I'm not gonna give you this image,
No, but it's interesting.
but I need to see it. Okay, here's better because you actually have the arrow. So do you see the contrast? Look at the contrast here and how the contrast here disappears.
Okay.
So here's exactly where the stenotic,
So how did it get?
So I eat stents if the doctor is good.
where the stenotic area is present. And again, even if you don't see the stenosis right there, look at this artery. You beautifully see the pelvis, the calyces,
Right.
And you can see the
and you
kidney.
see part of the image of the kidney. Compared to, tell me where's the pelvis, the calyces, and the other kidneys.
So you know further in the course of this one, you just damage that one with this ideal test.
Exactly. Okay?
Well, once you feel the stent and then
What you had is gone.
You
now know.
So, again, how do you best select, your diagnostic test? Unfortunately, even though renal arteriography and second of all, CT angiography are the gold standard examinations for renal artery stenosis, the majority of the patients cannot be done because they already come in with renal failure. Okay, and you're not going to induce more nephropathy with the contrast. Okay, if you have to use contrast, it's best to use MRA, which uses gadolinium, that doesn't affect the renal function as much as iodine, and you can even eliminate the soft tissue surrounding the pelvic organs. So basically excluding liver, spleen, and the whole mesenteric intestine and all that with the, the DEXA, the DSA, which is the DEXA exclusion angiography, okay? And again, the least that we can do on the patient, and that's actually the initial diagnostic test for a patient with renal artery stenosis, that we do it all the time in the hospital, is the renal ultrasound. And if you want to improve specificity on the patient, add Doppler to it to be able to measure pressure.
That's the renal vein ratio, right?
Correct, correct.
I like that.
All right? Any questions so far?
Yes.
So with this gold standard arteriography, since you're already puncturing the artery, can you technically go in and put in a stent right there?
Exactly. You can use it as diagnosis, the same as CAD. When the patient goes to the cath lab and you're doing a percutaneous coronary intervention,
Right,
if you
exactly.
see a stenosis or if you see a plaque, you basically put a stent. It could be with or without intervention, okay? So again, prognostic factors we already talked about, really depends on the, one of the prognostic factors is how the patient presented to you. The patient already has renal vascular hypertension or not, associated in organ damage or not, and also the renin vein artery ratio. Again, remember that when it's more than 1.2, 1.5, depending on the book that you read, is a really bad prognosis for the patient, not only due to intervention that is not going to resolve the renal function, but also increases mortality. Okay, it's all explained there. Treatment. In the past, and I want you to remember this because it's a controversy, and I don't want you to answer based on what's written in the PowerPoint, because that's the reason why I'm here, to explain the controversy, okay? So the controversy is, if you, okay, let me start with this. There is no absolute contraindication for the use of ACE inhibitors or ARB on a patient with unilateral renal artery stenosis? No, I am telling you. Now, if you give a patient an ACE inhibitors or ARB and the renal function worsens, of course you're going to discontinue it. Most likely is due because this patient is coming in the initial stages and is autoregulated. But there is plenty of evidence in research that, and it's in the guideline, that's why I'm here to bring you the guideline. There's plenty of evidence that there's more benefits than detriment or so more benefits than risk, let's put it that way. To give a patient ACE inhibitors or ARB, not to allow the patient to go into severe proteinuria and further renal damage when the patient's having unilateral renal artery stenosis. Do you understand? Because remember, let's go back to the beginning. Remember when I explained to you that when a patient is trying to autoregulate, this is a benefit for the organ, right? But when that organ goes into a vicious cycle, the complications are worse
So you're giving
than the
you're
benefits
weighing
of
the
the
risk.
autoregulation. Exactly.
Like,
So,
it's better to prevent the.
remember that I gave you the example of CAD and hypertension, okay? You have a patient with hypertension, as well as essential hypertension, renin-angiotensin-aldosterone system is released. Yes or no? Okay? And based on that, you treat the patient for hypertension, right? You can give beta blockers for the catecholamines, you can give ACE inhibitors, you can give aldosterone antagonists, etc., and diuretics, right? That's the reason, or how we treat any hypertension, okay? So basically, what we do is inhibit autoregulatory response. What happens is that when you inhibit autoregulatory response, you inhibit remodeling, which is a complication of uncontrolled hypertension. Do you understand? Okay, so what happens is that when the patient with hypertension goes into a vicious cycle, the patients develop ventricular hypertrophy, the patients develop remodeling, the patient develops end organ damage, including renal failure, including retinal abnormalities, including CAD, MI, and all the complications that we have gone through in prior semesters. And ACE inhibitors and ARB are one of the major medications that could inhibit the end organ damage. Okay? ACE inhibitors diminish left ventricular hypertrophy. ACE inhibitors diminish remodeling. ACE inhibitors diminish the proteinuria and therefore renal failure to advance. The problem is that you don't know exactly which stage is patient coming to you. When a patient with unilateral renal artery stenosis is given ACE inhibitors, if they are in the initial stages of autoregulatory response, unfortunately they need that to be able to compensate, to allow the normal kidney to perfuse the deceased one. So far so good? But you only are able to see that clinically, how the patient responds. So in other words, if a patient has unilateral renal artery stenosis, just because we know that by inhibiting autoregulatory response in the initial stages can deteriorate renal function, and that's how you can clinically diagnose this disease, it is not contraindicated to be given. Because if this patient is already on the vicious cycle of autoregulation, the damage or the dramatic effects or the complication of end organs effects of autoregulation can be more detrimental than beneficial. And therefore, we have to inhibit. You're still lost?
I'm not sure.
Do you wanna talk
Can I tap?
So when do you know? When do you know if they're in acute or you can't give it?
You cannot know until you give
You
it.
just give it no matter what.
You have to give it. You have to give it.
And then you CPR and creatinine over time if it keeps going up.
You have to give it. If it's unilateral, remember that.
Unilateral, yes, ACE inhibitors because damages are worse without it.
The only time,
That's it.
listen to me, the only time that ACE inhibitors and ARB are, and I have to do this,
Contraindicated.
contraindicated, and I'll tell you why I do this, is in bilateral renal artery stenosis. And if you read the guidelines or up to date or anywhere you read, in reality there's no contraindication because the little function that you have, ACE inhibitors will going to prevent further deterioration. But unfortunately, because you have no way to perfuse the kidney, if you decide to give ACE inhibitors or ARB on bilateral renal artery stenosis, it has to be done in the ICU. In a highly controlled environment. So you can measure very, very carefully and closely
Yeah, that
the
would be,
patient's blood pressure and renal function.
that would be the counter-breed.
Correct. Well, no, not the test itself, treatment,
Yeah.
giving lisinopril
IR
or giving losartan. Do you understand?
So
So again, as a summary, there is no absolute contraindication for the treatment of ACE inhibitors or ARB on any of the renal artery stenosis. Mostly, you give it for unilateral renal artery stenosis. If the patient gets worse, you discontinue it. And we have other options for them that we're going to talk about. Do you understand? Now, if you have to answer a question on a test,
just read me the question.
if you have to answer a question on a test, when ACE inhibitors and ARB are absolutely contraindicated, will be in bilateral renal artery stenosis. Why?
Because of the
Because you're
running.
not going to give it and let the patient go. Because the patient will stroke out or have any further complications. Do you understand? Okay? So, what are the options? So, what options do we have? So, again, medical therapy. And the medical therapy would be, first of all, controlling hypertension. And how do you best control hypertension on patients that have renal problems and diabetes? ACE inhibitors or ARB.
Can you give like a vasodilator?
Yes. But they're not the best. Now, what else can vasodilate that artery? Even better than an alpha-2 agonist, even better than central vasodilators, beta blockers and calcium channel blockers. Now be careful, because remember these patients come sometimes with a flash pulmonary edema. And in that case, then yes, beta blockers and calcium channel blockers are not indicated. And if you can give ACE inhibitors, the only option that you have is hydroxyzine.
No.
All right? So again, I have a patient that comes in that has unilateral renal artery stenosis. You put the patient on lisinopril 20 milligrams and the creatinine deteriorates. What will you do? Discontinue ACE inhibitors. How will you treat hypertension? Well, depending on the value. The same way you treat hypertension in essential hypertension. If a patient comes in with a hypertensive emergency, what will you get? Labetalol, nicardipine, same way.
Can you
Okay.
combine like
If
the
the patient's in flash pulmonary edema, you give nitroglycerin or nitroprusside. Same way. You just have to go back to cardiology. Okay? If the patients have values of hypertensive urgency and there's no end organ damage due to your endoscopic examination, your urinary creatinine is normal, which of course is not going to be normal most of the time, right? You have no left ventricular hypertrophy, your echo is normal, your EKG is normal, so you have no end organ damage. How will you treat hypertensive urgency? Hydroxyzine, same way. Okay? Now, what else can you give in hypertensive urgency? Isn't it enalapril one of the choices? Well, I would choose enalapril in this case better than any other. Better than clonidine, better than hydroxyzine. The renal function gets worse. Okay? Right? But you already have a renal ultrasound there, and you know if there's one kidney atrophy or two. And if both kidneys atrophy, and you're suspecting bilateral renal stenosis, then enalapril is not going to be your best choice.
So how can you choose from those ACE inhibitors? How do you choose which one you're going to use?
Because of the guideline that I taught you in cardiac. Hypertensive urgency, the best ACE inhibitor that is given in hypertensive urgencies is enalapril.
So, but I think there are some of them that work better with the kidney, some of them don't work.
Okay, if you have a patient outpatient that you're treating with renal artery stenosis and they don't have the values of hypertensive urgency, the patient only has 160 over like 98. What will you give? Well, you can give this enalapril. Yeah. Okay?
Can you combine like ACE inhibitor with a beta blocker?
Of course, the same way you treat, again, any hypertension. Now be really, really careful to dehydrate these patients with diuretics, okay? Unless the patients are on volume overload state, right? Right side of heart failure or pulmonary edema. Otherwise, be really careful, okay? What else can you do? As we said, well, we can just do the same way we do in coronary artery disease, do a percutaneous intervention and put a stent. In this case, going into the renal artery, right? You can revascularize the same way, and again, we can also do ultrasound, angiography, and remove the plaque. You could do the same way with the percutaneous intervention. This is the explanation of what I just gave you for the angiotensin, for the ACE inhibitors and ARB. And again, what else is missing? What initiated all this? Atherosclerosis. So, ATP3 guidelines. So how are you going to treat this patient? If there's no contraindication for statin, you're going to give statin. In this case, you don't think about if the LDL is less than 130 and the patient has 2 arrhythmias. No.
But don't the statins cause also like renal toxicity? So if you're in a patient of renal failure and you give statins, no?
The statins give renal.
They do, but it's like rare.
Oh.
It's rare. Compare more to liver dysfunction.
Yeah,
Okay, now the patient, of course, already has not only renal vascular hypertension, but also has hepatorenal problem. That's different. Okay. But if the patient's liver function test is completely normal, you have to give statin to these patients. Because again, that's what initiated the whole thing. And in addition to that, risk factors. Educate the patient. Try to eliminate the risk factors. Okay?
And hydroxyzine is a good choice.
Hydralazine is a good choice. Again, hydralazine is the last choice for treatment of hypertension in renal artery stenosis. Leading number 1, first line treatment for hypertension and renal artery stenosis is ACE inhibitors or ARB. No and, or ARB. In unilateral renal artery stenosis. Yes. Okay? The patient's renal function or hypertension becomes worse, you discontinue. And what other choices do you have? Well, I have beta blocker, give me metoprolol. Okay? You can put the patient on metoprolol, 25, 50 milligrams BID, the dose that you would start the patient on. Or you could start the patient, for example, dialtosen, which is a calcium channel blocker. You can give me dialtosen, 30 milligrams BID, or any other calcium channel blocker of your choice. Okay? But you have to know that beta blockers and calcium channel blockers are the best second to ACE inhibitors. Okay? So far so good?
Yes.
Depending on the numbers that the patient comes in as blood pressure is how you treat.
Right.
Because you're not going to give me metoprolol when the patients have 220 over 130. You give labetalol instead, or nicardipine instead. The patient has flash pulmonary edema, you cannot give labetalol or nicardipine. You have to give nitroglycerin or nitroprusside. Okay? Because you know that a patient with acute heart failure in pulmonary edema, you should not give beta blockers or calcium channel blockers. You memorized that, but now it's time to apply. Okay? So the procedure of choice surgically is to actually go there and put a stent. Or if you're able to see the plaque, remove it. Okay? So it's percutaneous transluminal angioplasty with or without stent to be able to open up and increase the function. Who has the better prognosis to improve renal function after the angiography? Remember the prognostic factor that I gave you, the vein artery ratio less than 1.5? Okay. That will be one predictive factor. Okay, and of course, catching it on time. I mean, you see that the treatment itself is improving renal function. When you do percutaneous angioplasty, of course the renal function is going to recover completely. And of course treat the underlying condition. Now, are you expecting a very high improvement when the patients have fibromuscular dysplasia?
No.
You have a stenosis, but you have nothing to remove from. You have no atherosclerosis, you have no inflammatory process to treat. It's just opening up the vessel. But this is a congenital condition that can reocclude more or faster than if the etiology was atherosclerosis itself. That doesn't mean that you're not going to do the transluminal angioplasty with stent, but you have to have in mind that these patients tend to reocclude more often than the patients with atherosclerosis, like 85% chances of reocclusion in fibromuscular dysplasia. Okay? So for example, showing here before and after angioplasty, you almost see no kidney. You only see like a little ball there with no definition of the arteries. And look here after the angioplasty. You can see the entire renal arteries and the calyces and everything after you open up, okay? Same way here, you have complete occlusion. You actually see only the shadow of the kidney, but you don't see the arteries and the calyces and look here after the angioplasty, okay? Same way, you have the renal artery stenosis here. You don't see the before and after. And again, as I said, with or without stenting, because the only thing that you have is just an occluding plaque. You can remove the plaque if there's no actual stenosis of the artery. If there is a stenosis of the artery, you can open up with a balloon or a stent. Okay? Let's see what else. So this is the process of revascularization and how the prognosis improves, and the surviving factors. Mortality decreases after you remove the plaque and or you put a stent. Okay? So as we already went through, there are several options for treatment, not only diagnosis, but also treatment-wise. You can also, for example, get the same way that we do in CABG. You can get an artery or a vein and do a fistula there to be able to reconnect. That's one of the major surgical interventions, but it's rarely done. The most commonly done is percutaneous percutaneous transluminal intervention of the renal artery. You can also get splenectomy and get the spleen artery and transplant it into the renal, so you can get more perfusion. Okay, the same way we do in CABG, exactly the same way. Okay. So again, now what are the major complications when you go with transluminal angioplasty and you're trying to break the wrong plaque, that the plaque embolizes? So you have to explain to the patient and the family members that this is a major complication. Patients can have an MI, stroke, a PE, okay, after this intervention. All right? And what is the criteria for revascularization? One of the criteria for revascularization is when you have, again, more than 70% stenosis of one of the renal arteries, but the practitioners tend to intervene more when you have bilateral renal artery stenosis, of course, because you still have with one, if you have less than 70% stenosis of one kidney, you have 60, 50, 55, 40, you still have one normal kidney that even though it's hyperfunctioning and trying to auto-regulate, still has a normal GFR and urinary function, okay? So again, the degree of stenosis, even though some book says 80 to 85%, we're now intervening to less percentage, so more than 70%, exactly the same as carotid stenosis, okay? And again, look for the risk factors, try to treat the risk factors, and the major risk factor is dyslipidemia, atherosclerosis, so you have to put the patient on high-dose statin. The same protocol for CAD, you know, when the patient leaves the hospital, you put the patient on dual antiplatelet therapy, right? You put the patient on high-dose statin, so exactly the same way, all right? And again, after that, what are you gonna follow? What you're gonna follow first, if you put the patient on ACE inhibitors or ARB, look for the blood pressure that is coming down, look for the renal function that is improving, and if it's worsening, of course, you're gonna stop and change antihypertensive treatment. If you do a percutaneous transluminal angioplasty and you do atheroma plaque removal or you put a stent, you're gonna look for the renal function that is improving, right? So basically look for all the values, urine and creatinine, and also check your LDL to see if the patient is improving, okay? So as one of the questions that she had, for example, patients can have a combination of course, remember, these are the patients that most of the time, one antihypertensive medication is not enough for them. So before deciding to do percutaneous transluminal angioplasty, if the stenosis is high degree, more than 70%, of course your first choice will be ACE inhibitors if the renal function doesn't get worse. But after that, what will you combine with these patients? Well, you will be adding beta blockers, you will be adding calcium channel blockers, right? So that will be the first three combination that you might choose. But again, remember, have in mind all the time that even with unilateral renal artery stenosis, since you don't know exactly what stage of the disease the patient presented with, patients can have a high deterioration of renal function, okay? So the message is, yes, give ACE inhibitors and ARB, and or ARB in unilateral renal artery stenosis. It is highly indicated because it will inhibit the vicious cycle of RAS. Unless the patient has bilateral renal artery stenosis, that for your exam is absolutely contraindicated, but in clinical practice, it is not unless you decide to closely monitor renal function and blood pressure on this patient. So you can take a break so I can read the case studies from my